Okay, so I'm going to go over some theories and nursing interventions and psychopharmacology for the somatic disorders. We'll go over somatization first. There shows to be a genetic tie, so increased incidence amongst family members. And the learning theorists believe that the gains perpetuate the problem. So the gains will be like the primary, secondary, tertiary gains. The primary being I get to avoid something, the secondary being I get attention, and the tertiary being, let's say mom and dad fight all the time and I now have a disorder, so mom and dad focus attention on me and now the family is happier. So that would be a tertiary gain, okay? So these gains perpetuate the disorder. Two nursing interventions I got out of the book that are related to somatization is ineffective coping, right? So because of the ineffective coping, instead of dealing with the actual underlying problem, the psychological problem manifests into physical symptoms. Okay, and deficient in knowledge being that instead of understanding that these problems are psychological, I keep seeking help from different doctors and getting drugs to treat the problem. Okay, so deficient knowledge. And then, so with the patient, first and foremost, you want to make sure that the problem is psychological. So you're going to, make sure you assess the patient, check the vitals, and check the labs to make sure that these problems actually are not of our organic origin, that they are psychological. And don't deny the patient of the symptoms, just to make sure that I emphasize this again, that these disorders, the patient's not making it up in their in order to get attention or to seek drugs. These symptoms are a physical manifestation of a psychological issue, okay? Whether it be, low self-esteem or ineffective coping or whatever it is, okay? So it's not making it up just to get attention. Okay, so don't deny the patient of the signs and symptoms, accept that those are real to the patient. And what you can do is initially you're going to go ahead and fulfill some of these dependency needs and these attention needs for the patient, but then you're gradually going to withdraw that attention away, okay? So the withdrawal of the attention is to the physical issue is going to hopefully reduce the symptom. So initially when you stop paying attention to the physical symptoms, the patient might become very the needs might become even stronger, but gradually it will lessen. Okay, and go ahead and identify those gains, the primary, tertiary, or secondary gains, and to see which gains are perpetuating this this disorder. And then encourage the patient not to verbalize and talk about the physical symptoms, but to verbalize the anxieties and the fears that they feel. Okay, so when I talk about gradually withdrawing, not gradually withdrawing, listening to the patient altogether, because you want the patient to verbalize their anxieties and their fears, but gradually withdrawing the attention away from the physical symptoms, right? Because that's maladaptive behavior, okay? And you want to do things to increase the patient's independence. Okay, this is not the patient you want to feed and do everything for and baby, right? You want to increase their independence. Because when they do things on their own and accomplish tasks on their own and get positive feedback, then they hopefully will get increased self-esteem, right? And the increased self-esteem will decrease the need for the disorder. Okay, and then you're going to teach alternatives of dealing with problems and psychological stressors that are not related to manifestation of physical symptoms. And teach the patient relaxation techniques, whether it's, it's really up to the patient, but if it's imagery or running or jogging or deep breathing, whatever it is, right, you want to teach the patient different alternatives to what they're currently doing, which is not coping with the issue effectively and having it turn into physical problems. Okay, so for the most part, the interventions for all of these, the somatization, pain disorder, the hypochondriosis, and the conversion disorder is the same. I just put a couple more things down here. So limit the time that is focused on the physical signs and symptoms, as in like maybe just allow the patient to talk about their physical distress for 10 minutes per hour, and that's it, okay? And then you're going to And if they refuse to do that, let's say they run into 20 minutes, and you're going to go and withdraw the attention away from the patient when they violate that, okay? So we don't want them consistently talking about the physical problems. We're trying to get the thought process to be on learning more effective coping mechanisms. And remember, priority, verify those signs and symptoms, even if, especially if they're, especially with the pain disorders, make sure that that isn't real. Make sure that they actually don't have a real issue, right? Because you never want to put the patient's health at risk, right? And do things to increase that self-esteem, increasing independence and the positive feedback for appropriate coping mechanisms is going to increase that self-esteem and increase that independence. And teach coping skills that are more effective than the obviously ineffective behaviors that are currently going on. Okay, so that's going to be the nursing interventions. So I already went over somatization, next we're going to go over pain disorder. So pain disorder, biologically, these patients have shown to possibly have a decreased level of serotonin and a decreased level of endorphins, and that might be attributed to the pain disorder. The psychodynamic theory believes that there is some sort of underlying guilt here for maybe things that they felt like they've done bad in the past, and this pain is kind of like retribution for what they've done. Okay, so there's a guilt aspect to this, to the pain disorder. The learning theories, again, believes in the gains, right? The primary, secondary, and tertiary gains. Two nursing diagnoses are appropriate for this disorder. For the pain disorders, obviously chronic pain and social isolation. Okay, so maybe these patients refuse to participate in group activities due to the perceived pain. So for your hypochondriacs, there is a genetic, not genetic predisposition, but a genetic link. So an increased incidence amongst family members. The psychodynamic theory believes that these people have poor self-esteem, right? So instead of feeling like there's something wrong with me, it's easier to believe that there's something wrong with maybe my body, my health, not necessarily myself, okay? And so they suffer from poor self-esteem. That's what the psychodynamic dynamic theorists believe. And then there's the same thing as the guilt aspect again, as we see in the pain disorder. Maybe I've done something bad and this is a retribution for something that I've done in the past. Whether it's true or not, there's a guilt aspect to it, okay? And the learning theory believes that that once again the gains, right? The gains for all of them, and then this is experience. So maybe this person has experienced an illness that really scared them, or maybe was with a family member that experienced an illness, and now it creates that hypervigilance and that fear. And the fear, right? Nursing diagnosis here, appropriate for the hypochondriacs is really they really fear that these diseases are real. Okay, not making it up for attention, but really there's a fear there. And often when they feel like they have this particular disease, it lasts like 6 months. Okay, and then so appropriate nursing diagnosis for the hypochondriacs is fear and poor self-esteem. Okay, and for the conversion disorder, once again, there's a genetic tie. The psychodynamics believe that maybe something happens to the patient, and they feel like what they feel is unacceptable and immoral, and now that emotion's converted into a physical symptom. And the learning theory, again, believes that it's the gains. And so nursing diagnosis appropriate for this patient would be disturbed sensory perception and a self-care deficit. Okay? So these nursing diagnoses that I put here, if you can memorize them, they are appropriate. Like, let's say ineffective coping is more appropriate for the somatization than it is for the hypochondriacs. But that doesn't mean that the person with pain disorder can't have ineffective coping as their priority nursing diagnosis. You just have to read the question to see, like, what are they trying to, what is the question asking, okay? And especially a person with a pain disorder, and for all of these, make sure to verify those signs and symptoms, right? That they are not real, with a real organic origin, because you never want to put the patient's health in danger. Okay, let's see what else. I think that's it. just memorize these. They're more appropriate for the disorder listed above, but that doesn't mean that this person can have this as a nursing diagnosis. You just have to read the question and decide for yourself that these are the most appropriate for that disorder. Okay, let's see. Oh, next. I couldn't fit in here, but we're going to go over some drugs and therapies. So, group therapy is very helpful for the person with the somatization disorder and the hypochondriacs, right? To meet other people like themselves, and for the other leaders of the group therapy to possibly call these guys out when they are acting in their maladaptive behavior. So being with people that can identify with your problem and understand what you're going through and provide support is very helpful for especially these two disorders. And then behavior therapy is very good, especially for patients who are getting that secondary gain. That's very powerful. Even some of us do it without even knowing it. Like, for example, when Dennis gets very sick, I give him a lot of attention, and maybe that gives him or perpetuates the problem, and he feels sick all the time because every time he gets sick, he gets all this attention, and I'm very nice, and that's not normal, right? So, and that's nice. People like that. So behavior therapy is really good at identifying the situation, maybe somebody that is actually encouraging this behavior at home, and kind of making sure that that doesn't occur anymore. Okay, so the SSRIs are not shown to work as well for these disorders, and tricyclic antidepressants used to be prescribed, but they have a lot of side effects. So the SNRIs are the real popular ones here, such as Effexor and Cymbalta. I put their trade names because I like the way they sound better, but these are SNRIs that are prescribed. Anticonvulsants such as Dilantin, carbamazepine, I think that's how you say that, or clonazepam. These are prescribed as well, and these seem to really help patients with the somatic disorders. And the patient with the body dysmorphic disorder, sorry, I didn't list this up here, but this patient's nursing diagnosis is a little more obvious than the other ones, so I figured when you see that on a test question, you could probably figure that one out because it's a little bit more obvious. But these patients do respond well to the SSRIs, such as Prozac, and the tricyclic antidepressants are prescribed for patients with body dysmorphic disorder, and pretty much like 50% of the time it actually does work. So these antidepressants work very well for patients with body dysmorphic disorder. Okay, well, I hope this helps.